This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 637, recorded on July 8th, 2020. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from southeastern Michigan, Kathy Spindler.
Hi, everybody. It's 32 Celsius and 86 Fahrenheit, but the 86 Fahrenheit feels like 91. So just so you know, it's pretty hot.
When you said 32, you usually give Fahrenheit first, and I'm like, whoa!
I know. I just want people to stay on their toes. Just have to listen.
It's a bit cloudy here. I'm home today. It's 27 C. If it were 28, it would be 82. So you can tell it's close to 82. Also joining us from Austin, Texas, Rich Condit.
Hello, everybody. Let's see. We've got 84 degrees and cloudy, headed for 95, which is relatively mild. We're going to have a streak of hundreds coming up here. And we are we have crossed into stage 5, the red zone, with a 7-day moving average of hospital admissions in the Austin metropolitan statistical area of 74.9. Stage 5 is, as it's written on the website, just short of a total lockdown. But that hasn't actually been declared yet. There have been no specific moves to honor that new status. I must say that despite the fact that the 7-day moving average for hospital admissions, which is my best indicator of what's going on, has been going up, the actual daily cases seems to be trending downward. But of course, the 7-day moving average for hospital admissions is going to lag that for a while. And in other news, the mayor has said that they are preparing to use the convention center as a field hospital, basically. And that'll be ready on July 20th. We are still hoping we don't need it. There's still hospital capacity left, but unless we get a grip on this, that's going to be exceeded.
And your governor recently required face masks for everyone.
Governor required face masks, closed bars, backed off on the restaurant recommendations. So he's trending in the right direction.
So New Jersey governor yesterday also now require face masks in public. That's been the case in New York for some time. However, whenever I go in, I see a number of people, maybe half of the people, not wearing face masks. I pass a playground in New York City, and all the kids, no face masks. I guess they leave home with them and they put them in their pocket or something.
Well, there may be some regulations about how old a person has to be before they do.
I see.
Have to wear a mask.
Depending on where it is. I've heard 8 years old, 10 years old, that kind of stuff.
Yeah. Well, our cases are ticking up slowly here in New Jersey, so the governor is slowing down the openings and so forth. I got a call today. My next week dentist appointment was canceled by the dentist. Interesting. I was going to cancel it actually because I didn't want to go. It's just a checkup, right? But I'm happy that that's canceled, so that's good.
I was lucky to have my dentist appointment 8 o'clock first thing on Monday morning after the office had been fallow since Thursday. So I thought that was good timing.
Did they have you gargle with hydrogen peroxide?
Yes.
How often?
Oh, is that right?
Yes.
How often? Every 20 minutes or something?
Oh, no. It was just a cleaning. And so it was just at the beginning.
I see. And they wore masks. How did they gown up?
So they were gowned, and she had double masks, and the outer mask had a plexi or almost like cellophane thickness shield attached to it. I was staring at her, and finally I said, how is that shield attached? And it was integral with the second mask.
Interesting. And you had glasses or some eye protection on? That's all, right? Because they have to get in your mouth.
Right.
All right. Interesting. All right. A couple of Brevia before we do some email. And I must say the email, something's happened in the last week, but the listenership has spiked back up again. The email has gone back. There was a little lull for a week or two. Not a lull, actually, but staying steady. Everything shut up. And so we'll try and get to as many of your questions as possible. We appreciate that you come to us for your questions. You know what I'm seeing a lot now? Journalists are contacting me and they hear us on TWiV, which never happened before. They never do that. They listen to they want to go to the source, I understand. But now they're saying, you said on TWiV the other day, I want to talk about that. Anyway. All right, so a couple of vaccine-related stories. China approves the adenovirus 5-based coronavirus vaccine for the military. Guys, did we talk about this vaccine at all previously on TWiV? Type 5, right?
I don't know that we've talked about this particular one, but we have talked about Ad5 vectored vaccines. I think there are a couple out there. I'd have to look at the landscape document.
I believe we have talked about this one. It's CanSino, so it's partly jointly with Canada.
So this was published in The Lancet in June 13th, safety, tolerability, and immunogenicity of a recombinant adenovirus type 5 vectored COVID-19 vaccine, a dose escalation, open-label, non-randomized, first-in-human trial. So that's out of China. And 195 people, actually 108 participants recruited into the trial. They got 3 different doses. It was mainly for safety, and what they saw was pain at injection site, fever, fatigue, headache, and muscle pain. Most adverse reactions were mild or moderate, no serious adverse. And then they measured antibodies by ELISA and T-cell responses. So now this is being approved for the military in China. There's no efficacy data, of course. And people are asking, why is this being approved and we're not? Well, there's no efficacy data. We would not approve a vaccine here without saying it works. So I was looking at the CNN article about this, and it's really approved for just 1 year. I don't get that.
This, to me, I mean, this just smells like essentially a phase 3 trial.
Exactly. Yes.
And using the military as a, guinea pig is probably too harsh a word, but probably the organization exists in the military to distribute it as well and keep track of it.
Yeah.
So, if you're in China, you can do that. You can say, okay, you guys are all getting the vaccine. In the U.S., the military, if I'm not mistaken, goes by FDA guidelines. They won't have their soldiers take any drugs or vaccines that are not approved or licensed by the FDA.
Mm-hmm.
But this is a different situation. The irony in this, like maybe this was in the CNN coverage, is that China says there have been 0 cases in their military. Okay,
hard to
statistically, it's not possible.
That's just not possible.
They have 1 million people in their military, right? At least.
I don't know, but
wow.
It's a substantial number. But whatever. I mean, it's an interesting test population.
Yeah.
Because I don't know to what extent the military, I just don't have any knowledge to what extent the military is integrated with the rest of the society.
Yeah.
So I don't know what their exposure is going to be. The other thing I think is noteworthy about this study that we've talked about before is that Ad5 is a pretty commonly circulating adenovirus, so there's a fairly high seroprevalence in the population. And they do parse out the numbers in this study between people who were seropositive before receiving the vaccine and those who were not. And they say that the seropositivity compromises to some extent both the antibody response and the T-cell response. But looking at the data, it doesn't look like it compromises it really in a very significant fashion. I didn't look at it that closely, but.
And I first saw this in an Ars Technica article, And they say that CanSino says they've reached an agreement with the Canadian government to conduct phase 3 trials there to look at efficacy and potential side effects in an even larger group of people. So they're doing that in parallel. And it also, CanSino declined to say if members of the Chinese military would be required to receive the experimental vaccine or if it would be optional.
Right.
They declined to say.
Right. According to
it
Reuters.
should be noted that a phase 3 trial, you're talking about tens of thousands of people if it's done right.
Right.
Okay. Because phase 3 is for efficacy, and efficacy judged not just by immune response, which is what's been measured so far in humans in any of these trials. That is whether you make antibody, whether you make T cells. And I'm glad they measured both in this paper. Yeah. Efficacy in a phase 3 trial is judged by whether or not it protects you against disease. So that's one of the reasons it has to be a large study. And it has to be on a study population that's going to be exposed to the disease in order to get a statistically significant measure of the effectiveness.
Yeah, I don't know if Canada is going to have enough cases to make that work well, but
even China now in some places, because they were so successful in cracking down on it. So I don't know.
Yeah.
We'll see.
Also in vaccine news, another member of the Operation Warp Speed. By the way, when I posted that episode, I made a typo in the post and I wrote Operation Warm Speed. And Andy Ball wrote, I think that's brilliant. I hope it's not a typo.
Andy Ball, good. I'm glad he's still listening. That's great. Hi, Andy.
It was it was a typo. Maybe even a spell check. I don't know if warp is. Yeah, I guess warp would be in there. It's just a typo. Yeah. So I fixed it, but yeah. Anyway, a new member of Operation Warp Speed, Novavax, gets $1.6 billion to make 100 million doses. So what is so this is very interesting because they have gotten previously 388 million from CEPI, the nonprofit that's helping develop vaccines, and I talked with the CEO in Singapore back in May to make it available globally, right? Because the Operation Warp Speed is for the U.S. and CEPI wants other countries to get it as well. And so this has been this is now in a phase 2/3 trial. It is called NVX CoV 2373, and this is from the HHS.gov website. It relies on a stable pre-fusion protein antigen made using the company's proprietary nanoparticle technology and Matrix M adjuvant. And so if it's a pre-fusion protein, that's got to be spike, right?
Yes.
Even though they don't say it. I don't know why.
Because they don't want you to jump on them for another spike basket thing.
That's right. They're listening to TWiV.
This is a purified protein, adjuvanted nanoparticle purified protein.
Actually, I looked into their technology as best I could, and the best I could find was on their website, which is Novavax.com. And it's not specified, but I was interested. There's two elements to this. One is the antigen itself, and the other is the adjuvant. And the antigen, they don't really specify, but they talk about their nanoparticle technology, and they've got this video that plays along with it. Okay, and it says that the antigen is cloned in a baculovirus vector, and for the uninitiated, that is a DNA insect virus that can be used to infect insect cells in culture and express proteins for purification. And that's an established technology that's used to make one of the flu virus vaccines. But based on their cartoon, the cartoon shows all of these little spike antigens aggregating in a three-dimensional star-looking structure at one terminus. Okay, so I get the sense that what they're calling a nanoparticle technology, and I'm making this up and I don't think I can find out because I think this is the proprietary aspect of it. I get the sense that there's some engineered component of the antigen that has them aggregate into nanoparticles that consist just of the antigen.
Mm-hmm.
And from that point of view, it's going to behave a little bit like a virus-like particle. Okay. And according to them, that has certain advantages in terms of how it interacts with the immune system. The other part of their technology is adjuvant. And once again, for the uninitiated, adjuvants are things that are added into vaccines that basically piss off the immune system and ramp up the immune response, and also help ramp up specifically the cellular immune response, so that you get not only an antibody response, but also a cellular response, which we've talked about before. And this is the technology is based on saponin, which is a crazy-looking amphipathic molecule. So it's got both a positive and a negative charge. It's a plant-based molecule that plants use for various things. But there's more to it than that. And that's proprietary, so I don't know what that amounts to. And I would also say, looking into this, that even though they have not yet marketed a product, they have several vaccines that they've been working on, including what they call nano flu, and another called ResVax, the former for influenza, the latter for respiratory syncytial virus, both of which are in phase 3 trials. Okay, so this is not, and they have several that have been all the way through phase 2. So even though they've not yet marketed anything, this is a technology that has been tested in humans in the past. So they're not just, this is not just out of the blue. This is they've been at this for a while.
Right. The New York Times made note of the fact that they had not brought anything to market yet, but that's also the case for Moderna.
Yep.
Sure.
So
absolutely. As a matter of fact, I would say that in terms of a technology that has had some experience, this is further along by a long shot than the Moderna vaccine. The Moderna vaccine didn't even undergo phase 1 trials in humans until very recently, whereas these variants, not the other variants, influenza and RSV, have been tested in this technology in humans for a couple of years now. So they have a lot of experience with this.
One of the things pointed out in this article is that there's no information on how Operation Warp Speed is deciding what to invest in, right? And one of the company people or NIH person, assistant secretary, says, we're putting a lot of effort into assuring transparency while not tangling them up in constant media inquiries, which I think is BS. You have to tell people what you're doing. That sounds like just nonsense.
Well, as I recall from the last time, I don't know if talk about warp. We're in a time warp here because I don't know how many episodes ago we talked about Operation Warp Speed. But as I recall, in the documentation that we did on that show, they very specifically identified 5 candidates that they were promoting. And I think there was some information on how they arrived at those decisions, but I forget the details. You can probably find it on the Warp Speed website, which we posted in a previous episode, but you could just Google search it and find it.
So John Moore, who's a professor at Cornell in New York, was quoted, "This is a sort of diversification from other approaches, which makes a certain amount of sense. You don't want all of your eggs in one basket."
Mm-hmm.
The eggs in the basket arc.
You know, I'm not sure it's it's a spike-based. It's not really that diverse.
Yes, it's spike-based. Well, it's diverse from the point of view that this nanoparticle approach is fine. Novel. And this is not a common adjuvant, I don't think. It's I think so.
Yeah, for sure.
And those for, by the way, I don't know if I actually said this, but the protein-only vaccines really need an adjuvant. Otherwise, you get strictly an antibody response and not necessarily a very good one. But one of the reasons that some of the protein vaccines that seem to have worked the best are the virus-like particles. And one of the things in my mind is the human papillomavirus vaccine,
Yeah.
Which absolutely blew away all of the immunologists, because that gives not only a robust antibody response, but an extremely durable one, which was unheard of at the time. And some of the thinking is that has to do with the fact that it's presented as a very dense cluster of epitopes in the virus-like particle. And I think we're going to have an opportunity to discuss this maybe on a subsequent episode, because I've been in correspondence with one of the HPV vaccinologists about this. But at any rate, it could be that the nanotechnology that in effect clusters the epitopes for the spike protein in a nanoparticle might have some advantages. I'm making that up, but that's the way I'm thinking about it. And that strikes me as the novelty of this approach.
So this is now in a phase 1. It started in May, and they say the results of phase 1 should be available in July, at which point, if it's good, they will start a phase 2. And so there's an article here in Globe Newswire. I'll put a link in the show notes. They quote Richard Hatchett, the CEO of CEPI, who said, our focus is on candidates that can be developed at speed and scale and made globally accessible. And they invested so that they would do manufacturing in parallel with clinical development. So if it works, you got doses ready to go. If not, it's a gamble, but they feel that it's worth that kind of gamble. Okay. Now, I think, Kathy, you put this Spain sero trial in, right?
I think it was Rich.
Well,
said we should
Kathy,
do it.
you and I have been
Yeah.
You and I have been bouncing back and forth on Slack about this. Okay.
Okay, that was it. Okay.
Tell us what this is about, Rich.
So this is
a Lancet paper.
Yeah, I think I saw this hyped in the news. This is a Lancet article, Prevalence of SARS-CoV-2 in Spain, a nationwide population-based seroepidemiological study. Okay. And this, I was impressed with this. Now, I'm willing to get bashed on that, but they did a serosurvey in Spain on 61,000 people from about half that many households. And so they did a point of care test, which is going to be one of these lateral flow tests to look for IgG and IgM. They kind of threw out the IgM results because they weren't as reliable. And they also, on some subset of these, did a different immunoassay that I didn't quite understand. Did you, Kathy?
No, I was counting on you really diving
I was counting on Brianne.
But I didn't think it was necessarily a subset. I think they tried to get everybody to get that second test. But that second test requires a blood draw.
Right. It was not
the first one
care.
Is just a pinprick kind of thing.
And my understanding was it was a different antigen as well, I think. Okay.
Yes, I think that's correct.
In addition, they, quizzed these people about symptoms, and they they had some PCR. I don't think, maybe all of them were PCR tested. And the bottom line is that the seropositivity in this sample was about 5%. So in a country that early on in the pandemic had as serious a problem as any country globally, and by some measures worse, but then was able to get it under control, at this point in time, the seropositivity is 5%. Of course, in the people who were PCR positive or symptomatic, it's higher. There's geographic variation. Okay, so there's a higher seropositivity in urban settings than in rural settings. But the bottom line is about the real take-home message here is 5%. Now, the question is, so how do you feel about that? The mistake that in my mind that the news media made is, in some report somewhere, it says that the conclusion is that herd immunity is, quote, unachievable, end quote, which is Nonsense. Okay. And I went back and looked at the article and searched it to see if that word was anywhere in this. And no, it's not. And they don't say anything like that. They just say we're at 5%, period. Okay.
Right.
Now,
it was the CNN article that the headline was Spain's coronavirus antibody study adds evidence against herd immunity.
It's ridiculous. Evidence against. Oh my God. Who wrote that headline?
So, some of this comes down to the public needs to understand what herd immunity means. It just means that a certain fraction, herd immunity is when a large enough fraction of the population is immune so that the virus doesn't have anybody to grow on, basically. I don't know if I'm surprised at all by this. Okay. The point is it's lower than I would like. Okay.
Sure. Yeah.
I would like us to be at 50 or 80% or something like that, though. That's crazy. The highest number I've ever heard was in New York City when they did that sero survey a few months ago after the peak of cases there. And some numbers, I don't know how reliable, came out with as high as 20%. But in other areas, I've heard 5%. So I've been thinking, maybe we're, sort of nationwide in the U.S., maybe 10%. If we were lucky, but that doesn't count all the rural areas where there hasn't been much spread yet. So basically 5% doesn't surprise me all that much, but it does mean that if you have to get up to 80% to actually achieve herd immunity, we're not even a tenth of the way there.
Right.
So hang on, dudes.
So just to give one more number, the seroprevalence was 17% in those who reported a history of symptoms compatible with COVID-19. So if you had symptoms, then 70% likely to have serums, but seroprevalent, positive serum. And as Rich said, like in Madrid, it was as high as 10 to 13%, whereas in the outlying areas, more like 2%. But I did find in the very last paragraph of the discussion where they wrote the following: despite the high impact of COVID-19 in Spain, prevalence estimates remain low and are clearly insufficient to provide herd immunity. This cannot be achieved without accepting the collateral damage of many deaths in the susceptible population and overburdening of health systems.
Okay, so it depends on how you want to read that.
Yeah, I guess.
They have not yet reached herd immunity. It doesn't say that you can't do it. Yeah. And it does say that in order to achieve it, we got a long way to go. And there's going to be a lot more carnage. Right. Okay. Absent a vaccine, of course.
And this is herd immunity as defined by positive IgG.
Yes.
Correct.
And there may be other things that are going to help define herd immunity.
Right. Yeah, I suppose you could say what's missing from this study, which, as we've already discussed, would be harder to do, is T-cell assays on all these people. Okay.
Mm-hmm.
Though some of the other papers that we've looked at recently, I'm unclear on this notion of how many people there might be out there that show only a T-cell response and not an antibody response. Okay. Sometimes it looks like some of the papers that we've look like that maybe even as much as half or even more of cases, people who've actually been infected, may show only a T-cell response. Other publications I've seen say that it's a much smaller percentage, maybe 10, 20%, something like that. So I'm not sure about that.
All right. One other paper I found, I was looking at a preprint that hit this week about development of rapid tests. PCR, the problem is PCR is costly and expensive. And it's the same. It's time consuming. It's costly and expensive. That's stupid, Vincent. Costly and time consuming.
Okay, Vincent, we'll forgive you.
And so can we get something faster and cheaper? We'll actually talk about that in the future. But one of the papers they referenced was this one, which, we may have discussed this, but I don't remember. But I want to just mention it again. It's published in Nature Medicine in, was it May? Which seems like ages ago.
Actually, 15th April.
15th April. Oh, it's like
Is when it went
That
online.
really was the Stone
Yeah.
Age.
Stone
Yeah.
Age. Temporal dynamics in viral shedding and transmissibility of COVID-19. This is a study out of China, and a couple of really good points I want to make from this. Okay, first of all, they say SARS, that's the original SARS, was notable because infectiousness increased around 7 to 10 days after symptom onset. Onward transmission can be substantially reduced by containment measures such as isolation and quarantine. And that's what Ralph Barrick said on his first TWiV. You know, SARS transmission peaks at around the peak of disease, and it's easy. Those people are in a hospital. It's easy to isolate and quarantine them. And then they say, in contrast, influenza is characterized by increased infectiousness shortly around or even before symptom onset. So that's why it spreads in the community. And so the question in this paper that they're trying to address is, what is the pattern for SARS-CoV-2? So they did two things. First, they took from 94 patients, 414 throat swabs from symptom onset to 32 days later. They look for viral RNA by PCR, and they see high loads right after symptom onset, and then they go down to the limit of detection by day 21. So this is PCR only, okay? Caveat, but that's what they find. Then they have transmission pairs. So two people, one who transmitted to the other, and they give them questionnaires, and they roughly know when their symptoms started, right? And they use these data to estimate the incubation period, and they come up with an average of 5.2 days. And then they take that with their PCR data, and they can see that shedding begins 2.3 days before symptom onset and peaks 0.7 days before symptom onset. And then it goes down really quickly within 7 days. And their estimate of the pre-symptomatic transmission is 44% in their cohort of patients. Pre-symptomatic.
That's huge.
It's
That's huge.
It's huge. Hey, WHO, did you read this paper? You remember a couple of weeks ago they said there's no pre-symptomatic, asymptomatic transmission? Come on.
Yeah. Yeah. This paper brings up two, what I would say are epidemiological terms that I was not really familiar with. The difference between a serial interval and an incubation period.
Right.
So the incubation period is the time from when a person is infected to when they show symptoms.
Right.
And the serial interval is the time when person one of the pair has symptoms, and then the time when person two of the pair gets the symptoms. And so they talk about how if the serial interval is shorter than the incubation period, then that's what leads you to determine that there's this spreading or transmission before the symptoms are even apparent.
They also quote two studies with high pre-symptomatic shedding in Singapore, 48%, in Tianjin, 62%.
Wow.
So this is really very important data.
Yeah. And no wonder this is getting around.
That's absolutely right. That's absolutely right. And that's more like influenza in terms of pre-symptomatic shedding, and not at all like SARS-1.
Right.
Now, an important limitation in all these papers, these epidemiological papers, they always at the end say, what are the limitations? And here, this is important. Symptom onset relies on patient recall after confirmation of the disease, right? And there could be a bias which would tend toward the direction of under-ascertainment. That is, a delay in recognizing the first symptoms. And they say, as long as these biases did not differ systematically between infector and infectee, the serial interval estimate would not be substantially affected. However, the incubation period would have been overestimated, and thus the proportion of pre-symptomatic transmission artifactually inflated. Okay, so that's a limitation, and it can only be addressed really by doing more studies in other countries, hopefully. But they conclude, disease control measures should be adjusted to account for probable substantial pre-symptomatic transmission. So Any reports you hear that there's no pre-symptomatic, it's probably not correct. This is a really nice study. All right, fine.
So I think of these things like measuring people's temperature before they engage in some sort of activity or something like that.
Yeah.
So, you could say, well, that's crazy, but it's I don't think it is, because even if there's as much as half of the transmission that is pre-symptomatic, there's another half that's symptomatic. And, with a few simple procedures, you may be able to screen those out at least. And it's interesting because I've seen at least conversation, if not studies, on how people report symptoms, because this is very subjective.
Yeah, of course.
Mm-hmm.
And what one person may say they feel awful under circumstances where another person would just shrug it off. Okay. So.
Yeah.
Mm-hmm.
The taking the temperature thing, we have a dichotomy. When I go in to do research, I go in through the same door into our building. You guys have both been there. It's down the steps,
right,
and into a door. And there's people sitting there. If you're a clinician, you just nod at them and say, yes, I'm clinician or whatever. And if you're doing research, you've already gotten the app and the little code on your phone where you've answered questions, and they take your temperature. And so if you're a clinician, they never take your temperature. If you're a patient, they don't take your temperature unless that's part of the physical exam. So it's not cost effective. And then I've heard of places where people do take their own temperatures with a thermometer that's there at the building, and then their wipes, and they wipe off the thermometer afterward. And that way they don't have to have people standing there to be the so-called greeters like we do. So there, a lot of variations on how this happens.
So to summarize, you're shedding 2 to 3 days before symptom onset. And then it peaks just before symptom onset, and it continues high pretty much for 7 to 21 days. So if you want to get an understanding of it, it always comes up. What are the numbers? Here it is. All right.
Actually, what's as impressive as anything else about this to me is that the shedding actually peaks before symptom onset.
Yes, right. That's right. Really interesting. Now, we did do a paper, now that I'm thinking about it, asymptomatic infections in China also a couple of weeks ago, which, if I remember, 30% is their estimate as well. So this is pre-symptomatic, and then they're asymptomatic.
And this does make the case, too, that this affects how you do contact tracing. You need to be asking people, when do you remember symptoms? And then at least be going 3 days before that of finding contacts.
Right.
And then, like Rich said, if they're tough and they don't notice their symptoms, that might not be enough.
Yeah. Okay, two brief things before we move on. These were just sent to me like a minute before I hit record by Amy. Amy is Amy Rosenfeld. That's my lab at Columbia, and she always feeds me news. And so first she sent me a link to a New York Times article. New York City schools will not fully reopen in the fall. Classroom attendance will be limited to 1 to 3 days a week, which is quite interesting, staggered schedules. And apparently there's been a tweet storm from the president, who is denouncing the CDC over guidelines for opening schools and threatening their funding. He threatened to cut off federal aids to schools that refuse to fully open this fall, and he assailed guidelines issued by the CDC that recommend a slew of costly preventive measures necessary to bring the nation's children back to class. I'm not sure he has any authority over local schools.
No, he's pulled this kind of stunt before, where he threatens to pull funding if people don't cooperate with him, and I've never seen it actually come to something. But I don't know. I don't know what could be the consequence of that, but certainly it's not behavior that I approve of.
course.
And there's also the pressuring of the universities where if a student is going to a online only for the fall type of university and they're here on a visa, they might have their visa revoked.
Yeah. And Harvard and MIT are both suing over that.
Okay.
That's just out this morning as well.
In the paper this morning, but actually on my wife and I have taken to watching the PBS NewsHour. Mm-hmm. We didn't watch any news for a long time. Actually, almost 2 decades we used to watch the nightly news, and then the Iraq War started, and we said, no, I can't do this. Okay, but we've started watching the PBS NewsHour recently, and they actually interviewed a couple of people on the schools opening thing last night. One of whom was an official in Texas who was basically saying, they don't have a coherent plan. And that it's hard to formulate a coherent plan because there's so much regional variation in what the schools need. Okay. But he seemed to be bemoaning the fact that there was no real plan. It looks like from the paper thing I saw this morning, it looks like they're planning on opening the schools, but with an online option so that parents who, for one reason or another, don't want to send their kids to school, there will be an online option for them. I don't know how that's going to work. This is a difficult problem. This is a really tough problem.
Yeah, we have some email coming up on school openings, and we will certainly come back to this in future episodes. All right, let's start some email here. We have an email from John Udell. TWiV stars thought it would be useful to clarify some aspects of B and T cell immunogenicity to extend your episode 634 discussion. Protein-based vaccines, like purified spike inactivated virions, will induce robust B cell and CD4 T cell responses, but 0 to very weak CD8 T cell responses.
Okay, stop there for a minute because first of all,
I can give my mnemonic. Okay, so
go.
CD4 are the helper cells, and 4 you call for help.
Ooh, good.
CD8s are the killer T cells. So CD8 annihilate.
Nice.
Oh, so, I think of CD8 as they ate something.
Well,
okay,
could be.
But we have generically talked about an antibody response and a cellular response. Okay, and I think that that's probably inappropriate vocabulary because I've been thinking of CD8 T cells, the killer cells, as the cellular response. But in fact, you induce CD4 helper cells, even in the absence of the killer cell response, if I understand it correctly from John here. So talking generically about a cellular response is kind of inappropriate in that context.
Mm-hmm. Okay. Now, note, you can't get an IgG or IgA immune response or B cell memory without CD4 T cell help. You'll only get a weak and transient IgM response. That's important.
Okay. That's important.
But,
nevertheless, he did say in his opening thing that purified protein-based vaccines will induce the CD4 helper response. Okay. So you could get B cell memory. Okay. But, okay.
All right. Now, nucleic acid-based vaccines, and this is RNA vaccines, DNA vaccines, and recombinant viruses, like the Ad5 we just talked about, will induce B cells, CD4 T cells, and CD8 T cell responses. All right, so that's good. That's all good.
Right. And the way I think of that is that a preformed protein, like in the purified proteins or inactivated virions, give you primarily an antibody response, though, as John says, importantly, you can get the memory response because you get CD4 help, okay, but not a killer cell response, whereas the nucleic acid vaccines and recombinant viruses, what they have in common is that it's not a preformed antigen that you're giving, but rather the antigen is made in your body, in your cells. And that's what's necessary to get the CD8 T cell response, if I understand it correctly. Am I making sense?
Yes, makes sense.
Yes.
Okay.
And that's true even if the vectoring virus is not replicating.
Yes, because you're making the protein in the cells rather than delivering it pre-made.
Right. All right. Full-length spike encoding vaccines will elicit antibody, and this is encoding, not protein, encoding vaccines will elicit antibody, CD4 T cell, and critically CD8 T cell responses. All right. Indeed, the unusually large size of spike, 1,273 amino acids, means that it has a proportionally higher number of potential antigenic peptides due to the major contribution of defective ribosomal products, or DRIPs, to peptide generation. All viral proteins are sources of class 1 peptides. That's class 1 MHC. For ER-targeted proteins like spike, peptides can arise from translation products that fail to make it into the ER and from misfolded proteins exported from the ER back to the cytosol for proteasome degradation / antigen processing. On top of this, there are probably peptides from low-level translation of alternative reading frames. I've attached a just-published DRIP review and an old but still relevant review on T-cell immunodominance for some of the gory details. So DRIPs, John, when he was on TWiV, he talked about this is work from his laboratory. Defective ribosomal products, the ribosome stops, little peptides are spit out, and those peptides can be displayed on MHC class 1. And
so what I take home from this is that if you're making the antigen on site, there are all sorts of ways to make antigenic peptides.
That's right.
Right.
Note that the Moderna RNA vaccine encodes full-length spike, while the Pfizer RNA vaccine encodes just the receptor binding domain, which is about 6-fold smaller than the full-length spike, encodes proportionally less CD4 and CD8 antigenic peptides.
I was not aware of that.
I do not understand why you would just do the RBD. Because
unless you're using a vector. No, it's an RNA.
An mRNA vaccine. The RBD doesn't have every protective. There are binding epitopes for antibodies outside the RBD. So why would you exclude those? What is the logic there? We'll never know because this is top secret.
I mean, if it were something like an adeno-associated virus vector where the coding capacity is limited or something like that, I might be able to understand it. But, in the absence of some sort of a restriction like that, I don't get it.
All right. Another potential advantage of the Moderna vaccine is eliciting antibodies to the non-RBD domains. Exactly. While these are likely to be inefficient or unable to mediate classic in vitro neutralization, they nonetheless may provide protection in vivo. It is clear from flu studies in mice, guinea pigs, ferrets, and monkeys that such non-neutralizing anti-HA antibodies, including antibodies specific for the stem of the HA, can protect against disease. Many mechanisms potentially contribute to protection by these non-neutralizing antibodies. These include Fc-based lysis of infected cells by NK cells and Fc-based phagocytosis of virus. And of course, the Fc part of the antibody is the bottom. The antibodies are Ys, and the bottom is the Fc that binds to receptors on cells. And this is
if you're watching, it's my elbows.
Do that again? I didn't see that. Oh, good. Very nice. Excellent. I have this problem with this. The document I'm reading is blocking the Zoom window. What do you got? Do you guys have multiple monitors?
I got.
I have a big monitor. Yeah.
I got I got a big monitor, but I got the document and the Zoom window. I got you guys stacked up vertically.
Mm-hmm.
Okay, in a shrunken Zoom window, and that's sitting side by side with the document.
Yeah.
Get with it, Vincent.
Well, I don't want to mess with the Zoom window because it's being recorded, and I'm afraid if I mess with it, then it's going to shrink. I mean, I should look at that. But yeah, this is so important because everyone's going after neutralizing antibodies, not just spike, which is all one basket or whatever, but neutralizing antibodies may not be it. And we talked about this for Ebola, those cocktails of monoclonals against Ebola. I think one that really worked well had a non-neutralizing antibody in it. So this is
and as we've talked about before, when you mount an immune response to a protein, you don't just make one antibody. You make a whole bunch.
Yeah.
And that's part of John's message here. And those things, in terms of protection, can essentially collaborate with each other. Okay. Each doing a little bit, and the overall effect is bigger.
Okay. Thank you very much, John. Very much.
Yes,
Yeah.
that was nice to have.
Very nice.
Anytime, we're happy to have your contribution. Probably should bring them back sometime. All right, Kathy, can you take the next one?
Sure. Keith writes, my daughter will be returning to Colby College in the fall, and see below, they will be testing everyone prior to arrival and then twice per week during the semester, along with other measures. Looks like a very sensible plan. Why can't others do this? And then, Vincent, you have put in the letter, which I did not look at, from the president of Colby.
I wanted to point out that it's one of the subheadings is a plan guided by the latest scientific knowledge. They're consulting with Harvard School of Public Health, Mass General, Broad Institute of MIT and Harvard, and using the latest knowledge to plan this. And I think that's just perfect because I've seen no other presidential letter that really says we're using science. They talk about testing, tracing, and quarantine. They're going to do 85,000 tests in the first semester alone, a number that almost equals the total number of tests administered in the entire state of Maine since the start of the pandemic. All right, this is a PCR test, lower nasal cavity, and he gives all the detail, and then he talks about additional mitigation procedures. I think this is brilliant, and it was what I was saying last time, what Cornell should do. And they said we don't have the money or the capability, and I just don't think that's a proper excuse. So this is in response to my complaining. I think that's.
I would point out that the undergraduate population of Colby College is 1,900.
Right,
So
it's much smaller.
Right.
Sure.
So they're doing these 85,000 tests.
That's amazing.
That is amazing. What I like too is that they list this variety of sources. One other one that you didn't mention was Maine General Health.
Mm-hmm.
So they're not just getting their input from one university's School of Public Health, for example. They're getting a variety of inputs.
I totally understand that it's a small school and Cornell is way bigger, but
it's the right approach.
It's the right approach.
Yeah.
And I can understand that maybe you need a cheaper and faster test. Just develop it. So I talked to some reporter yesterday about this. And I said, in World War II, everybody kicked in. They sacrificed everyone. You had soldiers, you had people back home doing stuff. There was no question. This is the same thing. You have to sacrifice. You have to do things. You can't make excuses that it's too expensive or you don't have time or you don't have the capability. This is a war, man. That's how I look at it, and you have to do it. And every time I see we don't have the time or the money or the capability, it really drives me crazy.
A lot of that is a leadership issue.
You think?
Yeah.
Yeah. Oh, yeah. I think so. I think, I was really curious to see what sort of pushback our governor might get when he initiated the mask requirement. Because initially not doing that was, I think, to some extent a political decision, if not to a large extent. Now, I don't know. I haven't been back downtown, so I don't know what sort of compliance there is, but I haven't seen a lot of pushback.
Yeah.
Okay. So if you've got leadership that is talking like you're talking now, Vincent, that says we're in a war and we need to commit resources to this and we need to get together on this, I think it would be a wholly different situation.
Yeah, I agree. I think it's all about leadership, and we haven't had a lot in this country. And people don't see the need to do all these things, right? So I was listening to a podcast yesterday from California, and they said all the grocery stores require you to wear a mask, and then everyone takes them off when they go in the store.
What?
Why would they do that? What's the problem, right?
Yeah. And every time you touch your mask, you're supposed to sanitize your hands.
Yeah. Yeah.
And you don't understand. There's virus on both sides of the mask, theoretically. So don't touch the mask.
Yeah.
Just leave it, put it on and leave it on.
Yeah.
It's disappointing that that the population is not more community minded. Put it that way.
Yeah. It's a good
Okay.
way
This notion that it is true that the majority of people are not going to be in serious trouble from this. Okay. It's not 99%, but it is a substantial fraction. But that's not an excuse for helping out the rest of us. Everybody pitch in. I mean, not everybody went overseas to war, right?
Yeah. No,
People
back
but
home
the people
did
who
stuff.
stayed home
Yeah.
made airplanes and stuff like that. And
Collected
rationed
tin
their
cans
food.
and grew victory gardens and all that stuff.
Well, we had a president who said, we're in a war. We got to do this. And we now have someone who's saying that now. That's the problem. Or part of the problem.
Exactly.
There's no leadership.
Yeah.
You can go on, Kathy.
Oh, right. So he subsequently sent this tweet from Alice Drager. 1, put all the undergrads in a closed arena together for 3 hours. 2, quarantine them with beer and condoms for 3 weeks. 3, carry out the bodies and send the rest back to class. This is why they won't let me be a dean. And for those of you who don't know, Alice Drager is the author of Galileo's Middle Finger, and you can check her out on Wikipedia.
So Galileo's Middle Finger is an interesting title. Do you know anything about this work, Kathy?
So she's done her research on conjoined twins, and also, so she's a historian, bioethicist, author, and former professor of clinical medical humanities and bioethics at Northwestern. In addition to conjoined twins, people with atypical sex characteristics. So she is not without controversy. And so I'll just leave it to readers to check it out if they'd like.
Given her tweet there, I can imagine that she would generate some controversy.
Right, and not be a dean.
Pretty good.
Rich.
David writes, Dear Vincent, love your show. I've only been listening since this current pandemic started, though. It has been fascinating to learn about virology. I heard your frustration re-university administrators claiming they don't have the ability to test their incoming students on one of the recent TWiVs. Check this CDC guidance out. The administrators you are frustrated with can now say the CDC advised them not to test. And the reason the CDC states appears to be incredible. And he quotes, testing of all students, faculty, and staff for COVID-19 before allowing campus entry testing, has not been systematically studied. It is unknown if entry testing in IHEs, what's that?
I'm not sure.
Institutes of Higher Education.
Right.
Provides any additional reduction in person-to-person transmission of the virus beyond what would be expected with implementation of other infection preventative measures, for example, social distancing, face cloth covering, hand washing, and enhanced cleaning and disinfection. Therefore, CDC does not recommend entry testing of all returning students, faculty, and staff, end quote.
They're going to kill us all. They're going to kill us all. It's unbelievable.
Yeah. It hasn't been systematically studied, so let's not do it. Let's not try it.
Sounds like the face mask issue, right?
Yeah. And if there's lots of people that are asymptomatic, then of course identifying them and making them isolate is going to be a good thing. It's just logical.
Yep.
This is disappointing.
Very disappointing. Yeah. And he's right. The many places will use this as say, see, we don't have to test.
Yeah.
We don't have to spend our money. I'm sorry.
Because there haven't been systematic studies about it. So, yeah. It's like, when they instituted seatbelt laws, people were wearing seatbelts before that, before there were systematic studies. So, yeah, the logic escapes me.
So anyway, I think Rich and Kathy, we disagree with CDC's statement on this. We think that testing, not testing alone, I just saw I just saw a headline about Tennessee, right? They conclude that they did a lot of testing and they conclude that it didn't help. But yeah, when you go back to a rock concert in big numbers and you go to bars and you don't wear face masks, it's hard for testing to make an impact, right? You got to do all of those things together. There's a headline in the Times today, Tennessee concludes testing is not useful. I mean,
yeah.
Oy.
Well, and if you get to a point where you have so many people infected that you can't do contact tracing, then it does become a problem.
Yeah, that's what happened because they apparently had this big rock concert with 1,000 people with no face masks a couple of weeks ago, and then everybody went to bars after. So they blew it, basically. You can't do that. But I think in a college setting where you have students coming in, you test them all. If there's some positives, you quarantine them. Then you do it multiple times a week. It works with distancing, et cetera, and everything else. All right, Rinat writes, hello, TWiVers. I'm a senior medical laboratory scientist from Israel. Here we are in the middle of the second wave, and unfortunately we're not dealing with it so well compared to the first wave. We are a little country with a high population density and very intimate familial society habits, which means it's not very easy to keep on social distancing physically and mentally. I'm an old fan of TWiV because virology has always been one of my favorite topics, both in university and in my professional career. A number of times on the show, you were talking about the urgent need of ramping up the testing and their key role in controlling the pandemic, but I don't remember even one time that you mentioned the people behind these testings, medical laboratory technologists and scientists, which you can't execute any lab tests without them. Not every step can be done by robots and machines. The medical laboratory profession is neglected for years by governments globally, not only in Israel and the U.S. Medical lab professionals got used to being unknown, unheard, and unseen beyond the curtain of samples, but now as the demand for lab testing is growing, you must understand that the number of testing is not just a matter of money or available reagents. It's a matter of how many lab professionals out there to execute these tests. In addition, they have the best knowledge about sensitivity and specificity of the tests. The decision makers should consult with them. Attached is a letter from the American Society of Clinical Laboratory Science, ASCLS, as a person who is involved in the Israeli Society of Clinical Laboratory Science and as one who tracks similar societies in other countries and ML's Facebook pages. I can assure you that the description in this letter is something in common to our profession globally. I don't remember the letter being attached. I think it wasn't, or if it was, I neglected to put it in, so I'm sorry. So I agree that we have neglected the people in the labs. We'll try and remedy that in the coming weeks. However, I'm sorry. I think you have to step up. You have to step up with money and time and people. And it's no, as I said earlier, it's not an excuse to say we don't have enough money, we don't have enough professionals. Figure it out. It's a war, folks. Figure it out. It's what we had 4 months for.
Yeah, and it just occurred to me that with that Spanish seroprevalence study,
yeah,
it's the beginning of the war.
Mm-hmm.
It is beginning. Winston Churchill, right?
The end of the beginning, right?
Yeah. I don't think we're even at the end of the beginning.
We're still in the beginning.
Somebody used the baseball metaphor and said we're in the second inning, which is, I think we might even still be in the first inning.
Or at least only the top of the second.
Okay, here's the letter. Let me just do some excerpts. Okay, it's from the American Society for Clinical Laboratory Science. It's written to Nancy Pelosi, Mitch McConnell, Kevin McCarthy, and Chuck Schumer. All right, those are majority and minority leaders of the House and Senate. So they're writing on behalf of tens of thousands of professionals. We believe we're unlikely to see the needed lab capacity for at least a month and perhaps more, even under the best of circumstances. And they go on to explore the kinds of tests that are being used. And they have shortages of reagents, extraction kits, other consumables, nasopharyngeal swabs. Understanding the dual causes of this crisis is critical to solving it. The labs are spread thin, don't have enough people. U.S. failed to support educational programs producing medical lab scientists and technicians, which I'm sure is true. We should be supporting it more. Annual cuts of more than $1 billion in Medicare reimbursements is a problem. And they say Congress must act immediately to reinforce a strained clinical laboratory system. This is great. So I will put this in the show notes.
Yeah, good.
But it's another reason we're not prepared, right? We had no pandemic plan. And certainly a clinical laboratory is an essential part of a pandemic plan, and there was none. And this is just part of it. So let's train some more for sure. Good letter. Thank you so much. Okay. Kathy, you're next.
Aaron writes, hello, Dr. Grumpy et al. I'm an avid TWiV listener, and while I, like many of the others, only heard about you when the pandemic started, well, it was an outbreak at that point, I thoroughly enjoy not only the coronavirus podcast, but the non-coronavirus podcasts as well. Oh, thank you. And I'm listening to the Georgia State one right now and really enjoying it. Yeah. Anyway, Aaron continues, I have gone back and listened to a number of them and have furthered my general virology knowledge. I'm an educator at a local community college in Modesto, California, and like everyone else, we are discussing fall semester. Unlike many junior colleges, not only do we have general education science classes, we also have a great cadaver program, which includes advanced dissection for students, a 2-year nursing program, and a 4-year baccalaureate respiratory care program. The students that make up our many science pathways include a fair number that already work in hospitals, such as CNAs and scribes, or work in hospice care facilities. CNAs are, I think, certified nurse assistants?
Certified nursing assistants.
Right. Okay. Anyway, so they have a lot of variety of allied healthcare students. We also have a robust career and technical program, and a lot of those students work in other high-risk areas, such as food processing centers, slaughterhouses, and meatpacking, and grocery stores. At the onset of this pandemic, I was naive in thinking that we were going to get a conserved federal response and guidance. Well, here we are in July, and those dreams have been dashed. We can no longer wait for a federal response, as one will not be forthcoming, at least until January 2021. We must do this ourselves. I very much subscribe to the Tetris plan of testing, tracing, and isolating. The testing seems to be a problem, though. Like many other places, we have some testing in the region, but not nearly enough. So to the point of this email, I am proposing that our school do our own testing. We have PCR machines. We have an abundance of health science personnel. We have good lab capabilities. That said, our PCR machines are aging, and through some roundabout funding sources, I want to get more machines. As scientists, do you have recommendations that you are willing to give out? Seems to me that any hope we have of being able to keep the majority of faculty, many of whom are at the at-risk population, staff, and students safe, we need to get this rolling as fast as possible. I love the podcast, especially the banter and occasionally submitted haikus. Stay pedantic, stay grumpy, stay safe. Aaron, and is a teacher at Modesto Junior College. So, this idea that, we can all do our own PCR, and I don't think that aging PCR machines really would be a problem. The important thing is going to be having the right positive and negative controls that are validated. And so if you can manage to get those, then I think even ancient PCR machines are probably going to work okay. I mean, as long as they're still functional. There's not that many bells and whistles to a new PCR machine, I don't think, with respect to heating, cooling, and so forth.
So is it, I retired a while ago, so I haven't been in a lab for a while. So to me, in my mind, correct me if I'm wrong, there's a difference between a PCR machine and a real-time PCR machine.
For sure.
Okay?
Yeah.
Oh, true. Okay, yes.
Now, maybe everybody now has real-time PCR machines, but these assays we're talking about are real-time PCR. So that's a slightly more sophisticated machine.
Yeah.
Right.
Sorry, for sure. And
I also don't personally have any experience with this particular test, so it's hard for me to evaluate how easy or difficult it might be to, even if you had an appropriate real-time PCR machine, to train an individual to use it appropriately, do the RNA extractions, use the machine appropriately, and evaluate the results. And I go back to the med tech letter that we just went over. I mean, this does require, under normal circumstances, some training, and I don't know how adaptable that is to a setting that's like this one described.
I think there's a broader issue here, and that is, unless you are, at least in New York State, any test that is where results are given to a person has to be approved by the state. And so we, for example, had someone who wanted to do PCR in a research lab and just tell people the results. You can't do that. You cannot tell people you're PCR positive or negative unless your test has been approved. I don't know if it's like that in every state, but that could be an issue to you doing that.
It makes sense because there's a significant liability involved in giving a person the wrong answer.
Yes, absolutely. Yes. So,
and I'm not just talking about money. I'm talking about real moral liability.
Exactly.
Okay?
Exactly. So I don't know how hard it is to get a test approved, but that may be something you might need to do as well. And real time is a little trickier than a regular old PCR machine. By the way, the old PCR machine, not a real time. You run it, and then you put the product on a gel, right? And you run your gel for an hour or whatever. So when I was in Sweden at the National Health, the CDC equivalent, they have this thing. You pipette the stuff on it, and in a minute it fractionates it. It's sort of like the sequencing machines that fractionate really quickly, and you read out by a dye. And this is the same thing, basically.
So it's like capillary.
Yeah. It was just this standalone machine, and you just...
Wow.
Isn't that incredible?
Wow.
Because it's a little laborious to pour your gel and run out the samples and stain it and take a picture, blah, blah, blah. Right? We're complaining. This is insider baseball here. Okay, Rich.
Rona writes, I am an eager listener of TWiV. Can you comment on how you feel about the health aspects concerning the reopening of my son's public high school on Long Island? In bathrooms using air dryers, I suggested the school disable the dryers and provide paper towels. The superintendent told me he had just read a piece by WHO that says air dryers do not present a hazard since the hands should be washed and clean. I said the issue is blowing air around and the fecal droplets from the lidless toilets. What can you tell me to convince him to disable the hand dryers? Incidentally, I asked if the bathrooms are vented, and he said they are exhausted. To what rate, I don't know. And would you comment on their plan to physically distance at 3 foot apart and have mandatory mask wearing? I'm concerned about the portion of who get exemptions from wearing. Thanks, Rona.
I guess the bathrooms are overused because they're exhausted.
This goes back to that report I saw last night on the news with the Texas school official who said that they would like to disable the hand dryers for exactly these reasons, but they don't have enough paper towels to go around. Okay. There are in lots of, and he would like to see the ventilation in the classrooms reach some certain standard, but we're talking about buildings that are 30 or 40 years old and don't meet up to the current standards. So there are serious limitations to meeting the specifications. Now, we've done papers before that show, yes, that these hand dryers, in particular, the air blade hand dryers, just blow stuff all over the place. And so, personally, I don't like them.
So I would tell the superintendent that it doesn't matter if the hands should be clean; they may not be clean.
Yeah, exactly. They're not going to wash their hands very well.
And also the point about the lidless toilets and whatever's already in the air being there. Yeah, and
Agree.
Just say disable the hand dryers, buy the paper towels, figure it out, figure out a way to make that happen.
I would also, if possible, and once again, there's a supply issue here, have hand sanitizer all over the place.
Mm-hmm.
I would hope that that's part of the provision. All these other things about distancing and masks and that kind of stuff, I don't have answers for that. They're all important questions that people are going to have to try and figure out.
And to me, the place to have it is by the door. So when I leave my building at the end of doing research, I've washed my hands. I take a glove with me so that I can push open all the doors between where I am and getting out. If they had hand sanitizer at the door, I could, take off that glove and then sanitize my hand. I mean, I'm supposed to carry my own, I suppose, but yeah.
I also go back to this, the conversation now. Okay, this is a non-coronavirus TWiV that I think we've published since the pandemic, which was one of the ones we recorded in Galveston, Vincent. Okay, where no, this was with Fred Murphy, where we were talking about high containment laboratories. And he was emphasizing that the single most important component of biosafety is the people.
That's
okay?
Right.
And so educating the students about best practices for reducing contagion is going to be the single most important approach to all of this, okay? Letting them understand what physical distancing actually means and why it's important, why hand hygiene is important, and all that kind of stuff. That's going to be one of the most important components, so that when they go into the bathroom, they can take whatever precautions they can with a clear understanding of what the impact of those precautions is. Now, with kindergartners, there may be a problem, but when you get up to high school, maybe we can make a bunch of public health experts.
That's a good point. Yeah, I really like that. But I think mask wearing is important.
Yeah.
Distancing, as you say, Rona. Yes, we agree with that.
But 3 feet? I don't know. If they could do 6 feet, it would be better.
Go ahead.
I was just going to say, I was walking through the hospital this morning, and people are not 6 feet apart, and I was like veering over to the edges of the hallway.
Yeah, it's true. It's true. By the way, I've been releasing a non-corona episode every week. So last year I did a lot of traveling, and some this year also, and I had all these episodes stored up for when we couldn't do a Friday episode. I would release them, but there are no Friday episodes because nobody's traveling. So I'm releasing them once a week. And so next week we're going to have Erling Norby Part 2.
Oh, cool.
And then after that, Rich and I did 3 in Washington, D.C. in February.
One of them we've already released. That was Fred Murphy.
We did
Bernie Moss.
Right.
And Eugene Koonin, 2.
And so we have 1, 2, 3 more to go. And then you're just going to have 2 a week. That'll be it for a while, because I'm not going anywhere for a long time.
No.
I got invited to a meeting today in Barcelona in February, and I'm like, no.
What?
No way. How can you have a meeting in February? It's crazy. I would love to go, but not happening. Not going anywhere.
You dudes only have 5% seropositivity. I'm not going.
And you're not letting Americans in at the moment.
That's true.
Okay. James writes, I love your podcast, and I'm learning more from you folks than I would ever get from any other source. But I wonder, do you agree with me on testing? I think the best way to fight this would be to test the asymptomatic population, even at the expense of testing those with symptoms. I mean, if you have symptoms, you already know what you need to do, which you should probably do anyway, whether you have corona or something else. I agree, actually.
Yeah.
I was talking with Amy about this yesterday. She said, in a hospital, if someone comes in with symptoms, just assume they're COVID patient and don't test them. And I agree. We have to, but I think we should, depending on the population, test everyone. If it's a school,
what we're hearing is that it's hard to test everyone, so you got to prioritize it. If you're going to prioritize it, I agree with this approach.
So guys like me and Rich, we're sitting home. We don't need to be tested, right? Maybe Kathy's going in how many days a week? 5 days?
Something, not quite 5 at this point.
So that might make sense to test you once a week.
Mm-hmm.
You're not getting tested though, right, Kathy? That's not in the plan.
Nope.
Because all 3 of us, by the way, are at the higher risk group, if you didn't know.
Right.
Because we're old.
Yeah, we're getting old. I love the email we got last week from the doc. Where he said the death rate is 1. Everybody dies.
Yes.
Unless you have a special arrangement with someone. That's great. I also wonder about two other issues. I've heard you say there's no evidence of two strains of the virus, which I must set aside my feeling that the virus coming from Italy seemed to spread worse than coming from China. I agree a hunch is not science, but I do want confirmation that allowing the disease to spread to get herd immunity is dangerous, because even if it doesn't seem to mutate quickly, the more people with a virus, the greater the chance that something such as a dangerous mutation will occur. Is that good science? It seems logical. Also, is there any evidence of links between coronaviruses and long developing problems such as cancer? There's no reason to think that having the virus infect more people will lead to any selection of any sort, because this virus, when it got into people back in China, it was already really good at spreading and causing the kind of disease that it does. It's just infecting more people. So it does sustain mutations in every patient for sure. We know that because we've been sequencing isolates, but there's no evidence that they confer any particular phenotype, and I don't see why you would assume that it would. I think that you don't want to let it run completely unchecked, because a certain fraction, 20%, are very serious, and those people need to go to the hospitals, and that's the reason why we don't want that to happen.
Right. And the hunch about the virus from Italy seeming to spread faster than the one coming from China. Remember that in China, people were already wearing face masks. Yeah. I mean, you've seen people in China wearing face masks for a long time. So there may be other factors there. And I agree, a hunch is not science. What seemed to happen in Italy was different from what seemed to happen in China, but there's a lot of other factors that went into that.
I think if you go back to Valeria Cagno, and when she was talking to us about the situation in Italy, she said they got caught by surprise. It was already there before they knew it, and that's part of the problem. Yeah.
He's got a. Go ahead.
Go ahead, Rich. It's okay.
He's got another little deal in here. Is there any evidence of links between coronaviruses and long developing problems such as cancer? Certainly, we've identified a number of sequelae, including these coagulopathies, clotting problems, and so the Kawasaki-like illness in kids. So there are rare complications that are showing up, and I would imagine that we will ultimately see more over time. That's certainly happened with Ebola, but it hadn't been long enough yet. Geez. We're barely 6 months into this. Can you believe it? It seems like forever.
That's what Daniel
we got a long way to go.
That's what Daniel always said. I always ask him. He said, we don't know. It's too soon. Long term. It's not 6 months. Yeah. Kathy.
Yeah. In our society, we're not used to the long haul anymore. You know, we're in the 15-second attention span mentality. Dudes, dig in.
Patrick writes, "Hi, I was wondering how difficult it is to engineer an attenuated virus, but with a much higher transmission potential. Release of such a virus could confer population-wide immunity at lower cost than traditional vaccines. It is easy to see how this could go very badly wrong, and there are ethics problems." Thanks, Patrick. So could you engineer an attenuated virus, so one crippled in its ability to replicate relative to a wild type virus, but with a higher transmission potential? So if we were all seeing, all knowing, we might be able to figure out how to engineer such a virus, but we cannot divine, I think, the characteristics that would give a virus higher transmission potential. Nature does it, and we just identify that.
Yeah, I totally agree. We have no idea what regulates transmission. And when people try to study it, they get hell for doing gain of function. Go back 5 years to the influenza H5N1 transmission story. Man. Oh.
Yeah.
Yeah, not only do we not only understand the genetic correlates of transmission, we don't really understand the genetic correlates of pathogenicity.
Nope.
Or immunity. So there's lots of basic science that needs to be done, not just on this virus, but on viruses in general. There's lots of unknowns. I remember when this first started, people expressed to me frustration and astonishment that we couldn't just look at the sequence and understand what sort of disease this caused and why. Okay? No.
The one attenuated vaccine that I'm aware of, there are a couple, I think, very few. The approach they're doing is to recode the structural coding region, which means you change the codon, so it's a different codon for the same amino acid, and that attenuates pathogenicity for reasons we don't understand. It's completely empirical, but that works for many other viruses, so this is what they're trying here. So yeah, we're really in a black box when it comes.
Yeah.
I was thinking also of there's a brand new dengue vaccine candidate, TWiV, which they deleted 30 bases from the 3' non-coding region of the viral RNA. I mean, it was just something they did, and they tried it, and it worked. I have no idea why this works, right? So, Rich, you are next.
Jonathan writes, hello. I am a new layman listener writing from southern Sweden, where the temperature is 20 C, 68 F, and it's windy and rainy. I highly appreciate that the podcast presents research and informed discussion in a manner that appeals to professionals and non-professionals alike, even if I can't follow everything you talk about. You've talked about the dangers of choir practice spreading COVID-19, but only briefly mentioned playing of wind instruments on TWiV 611 while discussing a Guardian article, and he gives the link to the Guardian article. I'm a member of a brass band that canceled all practice and performance during the spring, and I wonder what we will do in the fall. Like with singing, we push air out of our lungs with force, but the air goes through the instruments. Moisture from our breath condenses in the instruments, which we regularly release through valves. Yeah. Spit valves, right? You open these things up and the drool all comes out. God.
It's great.
I suspect most of the droplets and aerosols would get caught. The Guardian article mentioned that risk of spread varied with the size of the instrument, which makes sense since the longer distance for the air should mean more filtering. I'm worried that some smaller instruments like trumpets might spread the virus. I wonder what you think. I think we ought to put masks on all the instruments. Except that's not really going to do it because you got valves, right?
Right. And Rich, brass players will tell you that it is really mostly condensation that they are releasing, not that much spit. There's more condensation to
I'm not spit. Buying it. Condensation of what? Okay.
Your breath. Yeah.
Well, one solution would be to make all the brass instruments out of copper.
Yeah. I was just thinking that. Or silver.
But the clarinets, that wouldn't work, right?
No. Or oboes.
Yeah. But you can't make, that's obviously.
I'll tell you, if I were playing a wind instrument, I don't care what it is, I'm staying home till this settles down. Doesn't sound like safe practice.
So, there are orchestras and bands that get paid, and they're not doing any performances right now. But if it's just like these guys with choir, it's for fun and release, you just can't do it. I think it's a high risk activity, not just the fluids, but you're sitting next to each other, right? Well, I guess you could do it online, just like you could do the virtual choir. You could do virtual instrument. That would be funny. Isn't there some kind of video that someone made with like hundreds of people all synchronously?
Oh, there's plenty of those.
Yeah.
And in fact, John Udell told us his jazz combo was going to be trying out
cool.
Mumble or one of those ones that we've talked about in the past, right?
I think one of the most important things that we need to cultivate is patience.
Yes,
okay?
Absolutely.
This is going to take a while. Unfortunately, we need to reemphasize that there are a lot of people who can't be patient. I'm thinking about reports that have come out recently about the demographics of the infection and people of color being affected at a disproportionately high rate, and the explanation for that being that they are the frontline service workers. Mostly, okay? So there are plenty of people out there who don't have the luxury of being as patient as I can be, and my heart goes out to them.
Yep.
But when it comes to voluntary activities and this kind of stuff, anything you can do to mitigate the risk, and the way to mitigate it is just don't participate. Just, find something else to do. I've learned to work in my garden and do a lot of reading.
I hear people say, I have to go to a restaurant, I have to go to a bar, but you don't. You don't.
No.
Stay home. You may be young, but you're going to infect an older person, and it's not right. You don't have to. I'm next. David writes, great program, people, with 2 M's. Follow on.
And an E.
Yeah, you're right. Follow on from a question about thalassemia. Wow, this is an old one. Well, it's probably 3 weeks old, but both thalassemia and sickle cell disease patients will potentially have a sickle crisis when very ill, adding to the coagulopathy with COVID-19. Probably something that will be investigated retrospectively. Yeah, so I think this was a question posed to Daniel some time ago. Should these people worry? And so there you go. Okay, good.
We should define thalassemia. I probably need to look it up, but it's usually a defect in synthesis of one of the subunits of hemoglobin. Mm-hmm. And they're usually subcategorized, like beta thalassemia is a deficiency in synthesis of the beta subunit. And you wind up, anemic, basically, and other issues as well.
Rich, you're next. Oh, sorry, Kathy, you're next.
Ed writes, greeting from the People's Dictatorship of San Francisco, where it is about 509 degrees Rankine. From my understanding, the Fahrenheit scale is better for weather and normal use because the range is more expanded, not so compacted like the Celsius scale. Also, under normal conditions, when you use the Fahrenheit scale, you do not deal with a negative temperature like the Celsius scale. Well, unless you're in Ann Arbor or Wisconsin or
Edmonton,
the South Pole, Edmonton, right. Okay, but mostly you don't have to deal with negative temperatures. Both the Rankine and Kelvin systems do not use negative degrees because the concept is not thermodynamically or scientifically correct. One of my favorite quotes is from Goethe, "To know is to measure," and the other is mine. Mathematics gives discipline to science. Now, to questions. I have never taken a class in biology, but love your podcasts. Also, I get lost by the terminology, but try to get the concepts. For example, you say viruses are not alive, but you also say you kill viruses. I will not say who on your podcast has said that to protect the guilty. Should it not be that viruses are denatured? How can you kill something that is not alive? So we'll stop right there. So there is kind of a raging debate about whether viruses are alive or not. I think most of us agree that they're not. They're a nucleic acid surrounded by a protein, and they may or may not have a lipid envelope. When they are in a cell and they can replicate and carry out their virus life cycle, as we tend to say, some people consider the infected cell type of virus to be alive. Okay, I think I'm covering what we've covered in the past. Okay, so it's easy to misspeak and say that we're killing viruses when we mean we are inactivating them. So it's not exactly denaturing them per se, because denaturing to me connotes a particular kind of chemical reaction. But when we say a killed virus vaccine, we really should be saying an inactivated virus vaccine. But some of us have been in this field for a great many years and have used that language so long, it's hard to unlearn.
Yeah, people talk about live virus vaccines and killed virus vaccines, and those are, you're right, inappropriate terms.
Right. Okay. Another example, I first heard about sterilizing antibodies. Next, it was neutralizing antibodies. And now here you guys say protective antibodies. And sometimes I hear used antigens, and then I hear used pathogens. What is the difference? Do I need a Venn diagram to understand? Okay, so Vincent, why don't you take sterilizing antibodies, neutralizing antibodies, and protective antibodies?
So antibodies, of course, are made when you become infected with a virus or bacterium or anything foreign. And with viruses, we talk about antibodies that can block infection, because not all antibodies that would be made against the virus would block infection. So the ones that can, we call neutralizing antibodies. It's, for us, it's second nature to say that, but I understand that neutralizing doesn't mean a lot to most people, but we're neutralizing infectivity. Look at it that way. Now, I think what we talk about is not sterilizing antibodies, but sterilizing immunity. Mm-hmm. Whereas if you are vaccinated against, say, SARS-CoV-2, and then you're subsequently infected and the infection is completely blocked, that would be sterilizing immunity. Or if the vaccine allows infection, but maybe no disease, that would not be sterilizing immunity, because you're still making infectious virus. So that's, I don't think we talk about sterilizing antibodies, but rather sterilizing immunity.
Antibodies are probably involved in sterilizing immunity.
Yes,
but
for sure.
You're right. We don't talk about sterilizing antibodies.
And then
protective antibodies. I would make a distinction. This is good.
It is.
I would make a distinction between sterilizing immunity and protective immunity. Okay, because or protective antibodies, because you can get infected and the virus can establish an infection, but you can have sufficient immunity to tamp down that infection to the point where you never know that you were sick. You never have any symptoms. Okay, so that would be if antibodies were involved, those would be protective antibodies. But that's not necessarily sterilizing immunity. Sterilizing immunity, you don't even establish an infection. Agreed?
I would say that protective antibodies include neutralizing and non-neutralizing antibodies.
Okay.
Right? So sort of what John Udell was saying up top, right? So they both can protect you, but some of them neutralize, they block infectivity, and others have different mechanisms. That's what I would say are protective antibodies.
This is good because it digs into the nuances of immunity. Yeah.
We love these kinds of questions, by the way. Basic stuff we love it.
Mm-hmm.
Yeah, and we have a tendency to glide over some of this because we're used to it. So when you don't understand something, write in, and that will corral us and make us behave.
Right.
I think what she's saying, and what he's saying here, Patrick, is I hear used antigens, and then I hear used pathogens.
Got it. Okay.
So what do those terms mean?
Got it. Antigens versus pathogens.
Yeah.
Okay. So antigens are small portions of an entity, a virus capsid, or even an antigen. Well, an epitope is a part of a protein that is antigenic. So these are what stimulate the immune system. So that's what an antigen is. And then a pathogen is the entire infectious organism. And if you were talking about bacteria or fungi or parasites, they would be living organisms. Those would be pathogens. If you're talking about viruses, those are pathogens. But as we've just described, we tend not to think that they are alive. So antigens are just the portions of these microbes that can stimulate the immune system. And the pathogen is the entire entity.
Right. The word pathogen doesn't really say anything about immunity. Okay. It just says that it's a critter that makes you sick. Okay. But the
What's a critter? What's a critter?
Oh, that's a very specifically defined term. It's anything that replicates is a critter.
Oh yeah.
I think even trees are critters. Maybe you got to be able to move. I'm not sure. I'll have to think about this, Vincent. So let's spend some time here. This is a good question. And make a distinction between antigen and epitope, because those are terms we throw around a lot. Sure. And as we do that, I think, the people out there aren't going to get this.
Yeah, so I think, as Kathy said, an antigen is a molecule that will elicit some kind of immune response. And I just want to say it could be a protein, it could be a sugar, it could be nucleic acid, it could be carbohydrate. So it doesn't have to be a protein, right?
But it can be.
It can be, and most of us think of protein antigens, but they're not all. And epitope is a part of that antigen. It's a small part. It's the part that fits into a T cell receptor or an MHC molecule or an antibody. What, maybe 12, 15 amino acids?
Yep.
Or less. It's a small subdomain. Yeah.
Yeah, or less. Yeah.
So a whole protein could be an antigen, but that protein, and as a matter of fact, a protein like the spike protein of coronavirus may have many epitopes.
Yep.
Okay? Because there are different parts of that. It's got the spike protein is I don't know how many amino acids, but a lot. Okay. And so
163.
1,263.
That's what Udell said, right?
Okay.
Yeah.
So
God, I can't remember. I can't believe I remembered that.
So that's potentially what, 120 epitopes?
1,273.
Something like that,
Oh, but they're
roughly?
overlapping. I mean,
Yeah. Oh,
Yeah.
good point. Good point.
They are.
So that's
overlapping.
potentially a whole bunch of epitopes. Now, not all of those will behave as epitopes because some are concealed from the immune system in the structure of the protein and that kind of stuff. But it can have a given protein, a given antigen can have number of different epitopes.
Okay, continuing on, Ed's letter. Another question. When there is a COVID-19 outbreak at a food processing plant, can the virus be transmitted by the frozen food? China thinks so. Would not, when the temperature goes to freezing, ice crystals would form and destroy the virus? Or does the virus crystallize? Okay, so I don't know the evidence why China thinks that the virus could be transmitted by frozen food, but whatever. Depending on the conditions under which the virus is frozen, ice crystals might or might not destroy the virus. So we routinely freeze our viruses, not just at minus 20 Celsius, but even colder at minus 70 Celsius or minus 80. And that's true for viruses that have envelopes and viruses that don't have envelopes. I had this feeling, maybe just based on empirical evidence from having worked a brief time with VSV, that envelope viruses are going to be more labile to freeze thawing than are non-envelope viruses like the adenoviruses I work on now. But even with non-envelope viruses, when you freeze them and thaw them, you lose some infectivity. But freezing them is the way that we store them for long-term use.
Yeah, that's what I've heard you say before, Kathy. Hey, we deliberately keep them cold in order to keep them active. I won't say alive, active. Right. And in fact, in distributing vaccines, okay, some vaccines are sensitive to temperature, and some of these are replicating attenuated viruses. And so actually a significant problem in some vaccine technology is maintaining a cold chain for distribution of the vaccine. Yep. So the notion that cooling or freezing could actually extend the activity of a preparation of viruses is the appropriate way to think about it.
So back to the question about whether virus could be transmitted by frozen food, I think you'd have to invoke that there's a super spreader event. Maybe. I don't think it's highly likely in the scheme of ways to get infected.
Unless if you thawed it and then liquid was contacted you or something like that. But
right.
Yeah.
But if you thawed it and cooked it,
be fine.
Be fine. Okay. In science, words should have an exact meaning. I think Vincent knows that because he asks about the difference between data and datum. But who takes high school Latin anymore? And they're not teaching my grandkids cursive handwriting in school. We do not have standards anymore, and this country needs to switch over to the metric system so science will come more naturally to the kids. Sincerely, Ed. Now, rant. This is where I have to insert the letter that Dixon read a couple weeks ago. I don't think we gave enough attention to it because none of us had clicked through to the link. So it was a blog post by the late Brian Toss, who pointed out the benefits of using Fahrenheit. And because it does match it does have a wider range, and as we already talked about earlier on the show. So it's a really interesting blog post that I recommend you go to. He also commented on how he was talking to some carpenters in France, and they told him they like to do things in 1.2 meter increments because it's a number that's divisible by 2, 3, 4, and 6, and you almost never have to deal with decimal points. To which Brian Toss said, "Oh, like the foot?"
Right.
12 inches to the foot, for those of you who don't know that measurement. Yeah. So anyway, Rich was not on that show, and I wanted him to specifically pay attention to this because Brian Toss died of cancer June 6th, sorry. But he's quite the rigger, and I thought from his sailing interest that Rich would also enjoy seeing this site. So.
Yeah, this is a great article. The title is "The Metric System: Pigeon Measurement," which I think is terrific, and I really enjoyed this blog post. It's very good.
Yeah, I would love if we switched to metric because we all use it in the lab. It makes a lot of sense. But who said recently we can switch to metric except for temperature because they like Fahrenheit? Right?
Well, I would say that because if you use the metric system, you're going to always be giving temperatures in half degrees.
Yeah.
Because the degrees are bigger.
Sure. Yeah. Yeah, I understand the point about Latin. I just, and English is a living, evolving language. Things change and people use data incorrectly, but it doesn't matter anymore because everyone does it.
So Ed, this obviously we've spent some time on this. This is a great letter from Ed because he's really. I like hearing what people can understand and what they can't.
Yes,
and giving us an opportunity to explain it. This is great. So keep doing that.
Yeah,
he says it's from the People's Dictatorship of San Francisco. To me, People's Dictatorship is sort of an oxymoron, isn't it?
Yeah.
Yeah.
I also think many people may be afraid to ask these kinds of questions, but you shouldn't be because even we have trouble defining things, and it helps us to state them clearly, I think. So do.
Yeah. Early on, one of my friends from graduate school said, "Kathy, what's a D-dimer?" And I said, "Carol, I don't know either. And every time it comes up, I'm just afraid to, interrupt Daniel because our time with him is so short. And I feel like I should know." And then we looked up D-dimer.
I always emphasize to all my students that if you're in a situation like a class or a lecture or something like that, and you don't understand something, you're doing everybody a favor if you ask the question. Because if you don't understand it, contrary to what you might think, there's probably half the rest of the people there who don't understand it either.
Yeah. No, ask your questions. It's fine. Now Daniel has more time because he's home. So when he was in the car, we didn't want to ask him anything. But all right. Well, time has flown here. We've gone 2 hours, and it's time to stop because I have a meeting now. But that's TWiV 637. Questions and comments, twiv@microbe.tv. The website is microbe.tv/TWiV. And if you want to help us out financially, microbe.tv/contribute. Kathy Spindler's at the University of Michigan in Ann Arbor. Thanks, Kathy.
Thanks. This is a lot of fun.
Now you can go to lab and do some experiments.
Well, I think I'm not going today.
Okay, cool.
Yeah. But I am kind of going because there's only one person in the afternoon shift, and I want to be there for moral support for her. It's hard to be the only person in the lab starting in a shift at 2:00.
Rich Condit's an emeritus professor, University of Florida, Gainesville, currently residing in Austin, Texas. Thank you, Rich.
Sure enough, this is a really good one. This is a fun conversation. I like seeing you guys. This is, I was thinking the other day, matter of fact, this even came up in some correspondence with somebody about what I miss about not working. And what towards the end of my time as a professor, I thought what I'm going to miss more than anything else is the collegiality. Yeah. We used to gather in my office in the morning and just do this, right? And we'd have coffee breaks and lunch together, and we'd just do this. And this is great because I get to still do it. I thought I would miss it, but I'm still doing it. So thank you.
Glad to provide it. You bet. I'm Vincent Racaniello. You can find me at virology TWiV.blog. I'd like to thank the American Society for Virology and the American Society for Microbiology for their support of TWiV, and Ronald Jenkins for the music. This episode of TWiV was recorded, edited, and posted by me, Vincent Racaniello. You've been listening to This Week in Virology. Thanks for joining us. We'll be back next week. Another TWiV is viral.